So thank you very much for coming. I think it's very up a bit on the volume, I think. I think it's very good of anybody to be in such a hot room at 6 o'clock listening to such a talk. So it's called eHealth for self-managing long-term conditions. I'll change one letter as we move through the talk. My background is as an electrical engineer, but I was probably a biomedical engineer before it was fashionable to be, in that I actually did my doctorate in pediatrics, and the person who typed up my thesis is here today. So that's why I have to mention it. But I did my thesis here in this hospital, 2 floors up from here on level 4 in the Department of Pediatrics. I think I'm the only professor of electrical engineering that I've ever met whose PhD, or DPhil as we call them in Oxford, is in pediatrics. So it does give me a bit of background in terms of talking about the healthcare applications of technology, in this case mobile phone technology. So you can't do this sort of work on your own, of course, and this is only a small sample of the people I've worked with over the last 7 or 8 years, and you'll see why 8 years, 2002 is a critical date in a minute. But we've been working in this domain of e-health, remote health delivery, telehealth, and I'll introduce the phrase, the word mHealth a little bit later on. It's really a multidisciplinary collaboration enabled by the National Institutes for Health Research. As you probably know, Oxford is one of the 5 comprehensive biomedical research centres funded by the National Institutes for Health Research, and it brings together people from university and people from the Oxford Radcliffe Hospital Trust. And these are my clinical colleagues at the top that you can see there from the Department of Public Health and Primary Care, Professor Peter Rothwell, who's an expert in stroke, Dr. Carl Hennigan, also from Public Health and Primary Care. And the next bullet point is my current research team working in this area. There have been others before. These are just the current ones that I work with. And we also have associated with us a university spin-out company that has delivered some of the technology in order to make it sustainable and not just within a university research group. Now I'm going to focus, because it's a biomedical research centre, a BRC talk, on mostly what we've done within the BRC, but we've done quite a lot else, either funded by the Wellcome Trust. We've had funding from the corporate social responsibility arm of Vodafone, both the Vodafone Group Foundation and the Vodafone UK Foundation. And of course, as an engineer, I get quite a bit of my funding from the Engineering and Physical Sciences Research Council as well. But because of the talk tonight, concentrating on the BRC, I'll talk mostly what I've done in the context of National Institute for Health Research, but not uniquely so. So, bring you back a little bit. I'm sure most of you are old enough, I'm just looking at the age of the people in the room, to remember this. 25 years ago, we've only had these mobile phones 25 years ago, 25 years, and the first mobile phone call ever in this country took place on the 1st of January 1985 by Ernie Wise, of all people, from Docklands to Vodafone headquarters, in those days still called Raycall Vodafone, in Newbury, as I say, on the 1st of January 1985. And really, they weren't mobile phones at all until about 10 years ago, 15, 12 years ago maybe. This is what was allegedly a mobile phone, but of course it was really a car phone, because you need the car to support the battery that enabled you to use the phone. So I don't know if you can see it at the back, but that's actually a huge battery pack, and allegedly here's the mobile phone, but the weight of the battery was about 10 times the weight of the mobile phone. Therefore you had to have a car really to hold that weight. So mobile phones were car phones until the mid to late 90s. 10 years ago, they weren't very popular in hospitals, mobile phones. You probably remember the time when mobile phones were actually banned inside hospitals. So you could probably switch yours off, although there's not much of a signal in the John Radcliffe, but you've probably carried yours in. 10 years ago, somebody might have stopped you going in and said, you've got a mobile phone, switch it off, because it could interfere, in inverted commas, with the medical equipment. That was one worry. The other worry was the fact that if you kept using one of these, and it used to be a bit bigger, and had it glued to your ear for too long, for too much of the day, it might actually damage your brain. And there were various stories around. I've pulled this one off the web from 10 years ago, August 2nd, 2000. An American company being very worried about the fact that if their employees use, as they call them in the States, cell phones or mobile phones, then they could face the legal consequences if they didn't manage properly the health risks associated with electromagnetic radiation from the phone impinging upon the brain of the user. So that's just 10 years ago, not long ago at all. Now, what about today? Well, it's a completely different picture. In the US, this is just picking out a couple of bullet points. There's many more that I could have picked out. Verizon, one of the network operators in the US, launched a healthcare business unit, Verizon Connected Health. In the UK, just 6 months ago, both Vodafone and Orange announced new plans for the healthcare sector. Vodafone, just down the road in Newbury, have set up a healthcare business unit with initial funding of £6 million, quite small by their standards, but nevertheless substantial funding. O2 announced, not to be left behind, announced something in March 2010. So the whole sector, all the mobile phone network operators are becoming very interested in health. And one of the sort of best pieces of PR in a very sad context, very tragic context out of the earthquake in Haiti at the beginning of the year was this particular gentleman who was interviewed and filmed on the American TV network. And if you read the reports, for example, from NBC Miami, this gentleman who was medically qualified allegedly used his iPhone to treat his leg injury while he was stuck under the rubble waiting to be rescued. And he was stuck for several days. And so that gave a lot of publicity to the medical applications, the med apps, so they're sometimes called, that one can find on iPhones. And I have a bit more to say about that towards the end. So what has changed in just 10 years? Well, there have been quite a few studies, a report by Professor Stewart, a report by the World Health Organization, a paper in the BMJ in 2006, showing minimal health risks associated with normal mobile phone use, although that is caveated by the statement that you have to be careful with young children, and children under 12 are recommended to use their mobile phones for less than 10 minutes each day. But for the adult brain, minimal health risk associated with mobile phone use. There are ongoing studies, especially within the EU, but if you go on the Department of Health website and so on, they will tell you there are minimal health risks associated with mobile phone use. But as I said a little bit earlier on, what really changed everything was GPRS, actually called General Packet Radio Service, sometimes called 2.5G. Of course, we got 3G now, but GPRS was launched in Europe in 2002. And really, it was launched because people like to use these devices, these little cameras, in various places, including dark clubs at night. I think that's what most teenagers do, take pictures of each other doing usually fairly silly things. And then they like to send the equivalent of a text message, an MMS, a multimedia service message, of the picture that they've just taken with their mobile phone camera. And in order to do that, you had to have a service that allowed you to transmit and receive data, and that's what GPRS was. It allows for the real-time transfer of data, including, of course, medical data, and not just pictures from a camera, from a mobile phone camera, to and from a computer some distance away, a server, as we would call it, which is then going to send those pictures on to the phone of the person who the message is addressed to. So you're able now with your mobile phone and your keyboard to enter data and to review that data which has been received by your phone, for example, a picture or other similar matter. So what effectively you're doing when you're doing that is you're accessing the internet whilst you're on the move. So mobile access to the internet is now a reality. And as I've tried to hint, mobile phones are not seen not as the enemy of healthcare, in other words, potentially damaging your health, but a sophisticated tool that could facilitate the delivery of healthcare. So we've gone from eHealth, the remote delivery of healthcare using electronic means, to mHealth. So that's the one letter that I want to change in my talk. I want to go from eHealth to mHealth because I'm going to concentrate only in the applications, on the applications that use mobile phone, hence mobile health. The UK Department of Health conveniently on its website has various definitions, And I won't go through them all. The one which is closest to what I'm going to talk about is actually telehealth, which is the delivery of healthcare to distance using electronic means of communication, usually from the service user, in other words, the patient in this case, to a clinician. So a patient measuring their vital signs, it could be their blood pressure, it could be their peak flows if they've got asthma, it could be their blood sugars if they've got diabetes, and this data being transmitted by a telehealth monitor, which includes a biometric collection device, so a device such as a blood pressure cuff, a blood sugar meter, an ECG, an electrocardiogram monitor, etc., to collect the telehealth readings that are then sent by the phone. So my working definition of mHealth is to reuse what it says on the Department of Health website and just introduce the words mobile phones. So the delivery of healthcare to distance enabled by a mobile phone or a similar device. And if the mobile phone is used with one of these devices, such as a blood pressure cuff, a biometric collection device, then mHealth is a form of telehealth. And since we've all got one of these, just about, there are now more mobile phones in the country than there are people, because some people like me have two, because I have a BlackBerry in my other pocket. So it means that now more mobile phones than there are people in this country. There's 70 million mobile phones in the UK, 60 million population. So it's truly ubiquitous. Can we actually use it for healthcare application? Well, the answer is yes, multiple applications, but I'm going to concentrate on just one, that of long-term conditions which require regular management integrated into your daily life. And that's the key thing. This is integrated in your daily life. You carry it in your pocket or you take it with you everywhere. So why long-term conditions? What are long-term conditions? They used to be called chronic diseases in this country, and then I think on the 1st of January 2006, the Department of Health decided, there's a big edict on the website to say we were not longer allowed to call them chronic diseases, because there's the word diseases, we had to call them long-term conditions. There is a fair point associated with that. A person who's got diabetes or asthma or hypertension is not defined by the disease. It is a person with a long-term condition. So I've listed some of them there. They do limit your lifestyle, but if you learn to manage your condition properly, you can have a perfectly normal life. It's not a niche problem. In the UK, there are 17.5 million people living with at least one long-term condition, and quite a few million with more than one long-term condition. 12 million of those have got the conditions I'm going to focus on today: diabetes, high blood pressure, asthma, chronic obstructive pulmonary disease, COPD, which is really smoker's disease. The other 5.5 million tend to be people with arthritis or people with mental illness, could be depression, so on, which are long-term conditions as well. And indeed, in the university, there is work on texting people who suffer from bipolar disorder and try and match the text to the oscillations that they may have in their well-being or mood. So there are applications of the technology for those 5.5 million people, but I'm going to concentrate on those 12 million, approximately a fifth of the population. I'm not going to bother reading out what it says about the US because the numbers are mind-boggling. 1.4 trillion are the costs of long-term conditions in the US healthcare system. And one of the reasons for that is you will get $20,000 reimbursement to have your leg amputated if your diabetes has got sufficiently bad that you need, unfortunately, to have the leg amputated. But you won't get $1 to help you manage your condition and help you stay healthy so that you don't go down that path of gradually getting worse and eventually needing amputation of the leg. And I'll explain why diabetes can lead to leg amputation. So the costs are all at the wrong end. Actually, the costs associated with amputation, with putting somebody on dialysis, with living with the consequences of stroke, nothing at the moment with actually trying to prevent the slow decline towards these problems. And that's why we have such huge numbers here. Possibly even more frighteningly is because of the McDonald generation, as it's sometimes called, the number of people with diabetes will more than double in 30 years, from 2020-30. And at the moment, we've not done anything to change those figures yet. Of the babies born in 2007 in the US, it was reckoned that 1 in 3 would develop diabetes if nothing is done about obesity and so on. In the UK, diabetes affects just under 3 million people, so about a 20th of the population, but it takes a 10th of the NHS budget because you don't die of diabetes complications. You have your leg amputated, you may have a stroke, you may have to go on kidney dialysis, you often go blind because of diabetic retinopathy and so on. These are conditions that sadly you live with at much lower quality of life, and you need the support of a National Health Service, and that's why it costs almost £10 billion to manage diabetes. Now, diabetes is an interesting condition in terms of you have to spend now to avoid the problems 15, 20 years down the road. Therefore, it's very difficult to attract politicians' attention. But there are ways around that. Perhaps we can discuss that during the discussion time. Asthma is also a tremendous problem. Asthma is getting worse. Is it linked to climate change and so on? It's actually getting worse year by year. Levels of pollution, obviously, as you probably know, it affects children mostly. 1 in 8 children in this country suffer from asthma, but still 1 in 13 adults, so 3.7 million adults. So 5 million people affected by asthma every year in this country. Now, why there's such a problem? Your GP down the road spends 4 days out of 5 on treating people with long-term conditions. And in a hospital at John Radcliffe, 60% of hospital days are taken up by people who got 1 or more of these long-term conditions. And yet, despite all the efforts, you take, for example, diabetes, and I'll explain very briefly what HbA1c is. It's a measure of the long-term control of diabetes. 4 out of 10 people are above the government target, which is 7.5%. The number should be as low as possible. People who don't have diabetes, people in this room would have a number of 5.5%, 6% probably. If you're a well-managed person with diabetes, you'd be at 7.5% or below. 41.5% people are above this target. Likewise, the last year that we have audited, there were 80,000 hospital admissions for an asthma attack. And it's quite clear that about 3/4 of those could have been avoided. Why is that? Well, it's a phenomenon that we're well aware of as electrical engineers. It's called undersampling. This is somebody who turns up to their appointments to the diabetes clinic or the asthma clinic run by their practice. 45 minutes managed care during the year. This isn't to scale. So this is the 45 minutes in the number of hours in a year, 8,760 hours in a year. So it's the thin blue strip problem, if you want, that you may turn up to see your GP once a year, once every 6 months, but the rest of the time you're on your own. And we know, even if you don't have diabetes or asthma, that human physiology isn't constant. It goes up and down, and if it starts to go down, then you end up an emergency admission to your hospital or an emergency visit to your GP. So really, you need to self-monitor in between to avoid those costly emergency admissions to hospital or the emergency visit to your GP. And I haven't got too many slides with equations. In fact, this one doesn't have equations, but there is a plot anyway. This is one of the teenagers we worked with in the early days when we were developing our technology for somebody with asthma. Along the horizontal axis, 25th of February, all the way to 20th of May. So it's the start just before the pollen season, which starts about here in mid-April. And what this young person with asthma is doing is blowing through a peak flow meter. So that's effectively a measure of lung capacity every day, morning and evening. And their normal value is about 280 litres per minute. But of course, you never quite blow the same. You never quite the same morning and evening. So it goes up and down a little bit above what we call a trend in red. And we use sort of computer processing to extract the trend so that you don't pick out isolated points. You follow the trend in red. And so these are just the normal variations that somebody might experience. Then the pollen season starts, and this person begins to come down very quickly. And because he's self-monitoring and doing his asthma diary on the phone, so here are the symptoms. You can see they get worse here in yellow around about that time. And he's starting to use his puffer, his reliever inhaler to try and manage. But we send him an alert to say, look, because most people cannot pick out in the variation that you have from day to day what is a negative trend unless they get information back on their phone. Say, this is sufficiently serious, go and make an appointment to see your GP, goes to see the GP, is put on steroid inhaler for a short period and recovers until the next exacerbation begins to develop later on there. But you are getting feedback. So the patient is self-monitoring their peak flows and their symptoms recording, and it provides information which allows them, once they've learned to identify trends, to self-manage or to receive an alert which allows them to go and see the GP before it gets too late. So it's this ability to record, monitor, understand what's happening, plus alerts that are sent before the physiology deterioration is too serious. That's what we're introducing with eHealth. That's the thin blue strip. This is the normal variation for 4 months of somebody with asthma. And of course, even if they turned up to their previous asthma clinic visit, it'd be over there, and the next one's going to be over there. So it is providing them a means to self-manage, to self-care between the visits to the GP surgery. And so this is a well-known phenomenon that you could actually teach people to self-manage, and their asthma, their diabetes, their blood pressure isn't that bad, and this applies to 70 to 80%, about 3/4 of the people with long-term condition. And if they learn to self-manage properly, then they probably won't graduate to the next level of what's called the long-term condition pyramid, which is disease management, high-risk patients, sometimes called the frequent flyers. They keep coming into hospital and out again, being discharged to community, and then back in again, another exacerbation, for example. And the highly complex patients, then these are people, for example, that might be in nursing homes that have to be managed very closely daily. Our technology is at this level with some work here, but mostly at this particular level. And you can minimize the complications in long-term conditions if you give people a tool, in our case a form of technology, and it's not the only tool there is. There are others, there are training courses, there are support groups, such as the expert patient support group, etc. But the mobile phone, being such a ubiquitous tool, is a form of technology that's going to hopefully help people to remain in the lowest level, level 1 of the long-term condition pyramid. Because there is plenty of evidence that if you have the right self-management program, then you can stay well controlled. The problem is, how do you move to a program that can support the millions of patients that could benefit within the NHS? And we've focused on the mobile phone from the beginning because, as I said, 90% UK population owns a mobile phone. It's now a portable device that gives you real-time data entry and review. You can communicate with the remote nurse who's got the same data as you have and therefore can talk you through what's been happening. And there's a health economic argument that the technology pays for itself very quickly by the reduction in unplanned hospital admissions. I'm not going to go through the economics. I've got some extra slides if anybody wants to talk about it after in the question time, but there's a very strong economic argument as well. So what do? Patients have and I'm going to illustrate with diabetes here, a mobile phone in their hands and their blood sugar meters. For those who are technology minded, we can give them a Bluetooth connection to the phone. For those who prefer not to have Bluetooth, they can type in their reading. And effectively, what you're doing then is using the internet to transmit the readings, all automatically done when you just press go, as it were. The data arrives on the server via the internet, and two things happen. Information goes back to the patient. This is the immediate feedback to tell them, for example, if they're deteriorating. And a nurse who could be in the GP practice, could be in the remote telehealth center, could be in the hospital, there are various models, sees all of that data, and it's automatically prioritized by the computer to rank the patients in order of priority so that she can then phone the patients and help them. So there's two aspects to this. The mobile phone is an interactive tool that promotes self-management, but you also get regular support from the telehealth nurse based on the data. So the data that she sees on her screen is exactly what you have on your phone. So there's a really evidence-based conversation that goes on. So just to give you some examples, you have your patient diary on your phone. These are just screenshots. For somebody who's got diabetes, how long was it since you had a meal? Then we know it's a reading before breakfast, when they first wake up, before a meal or afterwards. question about exercise, and then you either enter your reading, and I think the video is still on the BRC website if anybody wants to see a live demonstration of it, or if you've got Bluetooth, that's not British Telecom, that's Bluetooth, you press that button, the reading is automatically transmitted to your phone from the meter. You get some information back showing you're trying to stay within those 2 levels. That's the millimoles per litre. So those are green readings. When you go too low, that's a blue. When you go above, it's a red. And then you get kind of longer term screens, which I won't explain. But again, you're trying to stay in the green, not going to the blue, which is too low, or the amber and red, which is too high. So that's on the left, the diabetes. For asthma, we developed an application for one of the O2 phones 5 years ago, where you had your own barometer, your peak flow. My peak flow was on the green to red scale, and you also got the local weather and local pollution levels, air quality, because we know when you have a mobile phone where you are. So if you go and visit your sister in Newcastle tomorrow, you'll get Newcastle's weather rather than Oxford's weather. The nurse has got a screen which allows her to manage all the patients, and this can literally be hundreds of patients. And she can drill down and see exactly the same pictures you have on your phone. She can send you GPRS messages or text messages and so on, and have that communication that most of us are familiar with, but in this case about healthcare data. Now, as I'm sure you know, most of you here will know, medicine is no longer a single word, it's 3 words. EBM, evidence-based medicine. You cannot introduce a new technology, a new intervention, without doing the clinical studies or trials, and the BRC is very strong on this. Most of us are involved in clinical trials. For my sins, happen to be principal investigator or co-investigator on 7 live clinical trials at the moment. And these are some of the ones that we've done. I'm only going to concentrate on diabetes briefly, just to tell you the kind of evidence that we've got working with clinicians. And I'm going to concentrate on diabetes so that the points that I'm making specifically about diabetes can be used for other conditions, but I thought I'd tell you a little bit about diabetes. You may have friends who have to inject themselves because they got type 1 diabetes, an autoimmune disease that destroys the cells in the pancreas that produce insulin. So you have to have exogenous, from outside the body, insulin by injecting yourself. And if you don't do that, it can actually kill you through diabetic ketoacidosis. That's about 10% of people, 250,000 to 300,000 people in this country. The other 2.5 million of people who got type 2 diabetes, when effectively your pancreas is gradually giving up, not producing enough insulin, or the body's not using it effectively enough. So usually when it's first diagnosed, you're given a diet and exercise program, then you go on to medication, then you go on to multiple oral medications, but eventually, towards the end stage of the disease, you have to switch to insulin injections. About 25% of people, type 2 diabetes, have to use insulin. So the problems I've already mentioned, why diabetes is such a tightrope, is that if you keep your blood sugars too high by not giving yourself enough insulin, then you have the problem in the long term, small blood vessels, microvasculars in the eye, in the kidney, and in the nerve endings, will lead to blindness, diabetic retinopathy, kidney disease, meaning you have to go on dialysis, and low limb amputation because of the problems in the vessels in your foot or low leg. So that's the reason why you have to keep injecting yourself insulin. You will go blind within 10 to 20 years if you don't. However, if you give yourself too much insulin, you suffer from the opposite, which is hypoglycemia, low blood sugar, and that can make you dizzy, that it can make you faint or go into a hypoglycemic coma. So the whole thing is a narrow tightrope. You mustn't be on the right-hand side, on the left-hand side. In addition to that, most people with diabetes end up having high blood pressure, which can lead to coronary heart disease or stroke. And those are the long-term macrovascular, the large blood vessels in the body that can give you those problems of either heart attacks or strokes. Self-management is measuring your blood sugars in millimoles per litres. People who don't have diabetes, I'm probably between 4 and 5 now because I haven't eaten since lunchtime. If I have dinner, immediately after dinner, I'll probably go up to 8. That's the kind of normal variation. Those variations fluctuate much more in somebody who's got diabetes. However, these are the short-term fluctuations. The long-term control, how well you manage, is through the HbA1c test that I've mentioned before, and that you have to go into the hospital clinic to have that test, or your GP, and it's a measure of your long-term control over the last 120 days or so. And in other words, 4 months. And really, for people with diabetes, as I said, around 4 to 5%. For people with diabetes, you really ought to go down 6.5% if you can, but the government target is 7.5%. Why? Because for every 1% drop in HbA1c, so if you're 10% or 9% or whatever, and you manage to bring it down by just 1%, so the HbA1c might go from, say, 10% to 9%, that's a 33 to 37% reduction in the risk of the microvascular complications. Remember, kidney disease, retinopathy leading to blindness, lower limb amputation. So you would imagine that everybody would want to drive their HbA1c as low as possible if they had diabetes, but actually it's very difficult to get these messages across to the general population. That's why 41.5% are still above the government target of 7.5%. What can we do to help them? When we started with, this was prior to BRC days, people from the Young Adult Clinic, which is at Churchill Hospital, and aged between 18 and 30, they were using mostly what's called basal bolus, injecting insulin at night and then topping themselves up according to what they were going to eat. And they had poor glycemic control, somewhere between 8 and 11%, and we were trying to bring it down by 0.7%. We had 2 groups. It was what's called a randomized control trial. Some people randomly went into the intervention group, some people went to the control group. It's actually quite difficult to know how to decide how to design the 2 groups. We decided to help recruitment to give everybody a mobile phone and a Bluetooth blood glucose meter. And the control group did an electronic patient diary, but the intervention group got the feedback I was mentioning, telling them how they were getting on, both short-term and long-term, and a call from the telehealth nurse at least once a month. I've only got one figure deliberately because I didn't want to flood you with data. This is what we call patient compliance. Very simply, the number of readings received per patient per week. And if you look at the first 4 weeks, the red and blue groups, red intervention, blue control, about exactly the same. You get a nice new piece of kit, you learn to use it. So we asked them to do lots of readings first week and then say, okay, you're on your own. And for the first 3 or 4 weeks, roughly the same. But the control group, without the feedback and the support, gradually comes right down over the 9 months of trial, where those who had the feedback on their phone, telling them how they're getting on, occasional call from a nurse, the compliance, number of readings at the end of the trial were as good as in the first 4 weeks. That was the power of the technology to help them manage their condition. So I'm not going to go through all of those, but we had a statistically significant reduction in the HbA1c. We didn't quite manage 0.7%, but we managed 0.6%. And the number of people that were well controlled, we started at 18% in the control group, hardly changed at all. Started 11% in the intervention group, but more than quadrupled to 49%. So we had nearly half of our patients in the intervention groups were well controlled by the end of it. And we did this without spending huge amounts of resources. On average, the nurse only spoke to them for about 10 minutes per month, those patients in the intervention group. And at the bottom, I put the papers where we've published this. So if anybody wants the publications, you can chase me afterwards, or I can do this to the screen, whichever is easiest. Before I finish, I intend to finish about 1:45. I want to debunk a couple of myths. The first one is that this is all very well for people with a young adult clinic between 18 and 30 because they're used to using their mobile phones, and it doesn't work for people at the other end of the age spectrum. That is a myth. And we find that, in fact, the elderly people are far more regular with their readings. So we took on the hardest thing, which is people on type 2 diabetes who have to move from using oral medicines to learning how to inject insulin in their 50s, 60s, or 70s. A very difficult thing to do, and very often doesn't really work very well at all. So we did a study with patients from 15 general practices in Oxfordshire, mean age of 58 years. You can see problem of lack of controlled diabetes, mean body weight of 97 kilos, BMI of 32, and a fairly high HbA1c, 9.5%, 2% above government target. Some of them on insulin, some of them without and not using it properly, and others not on insulin yet. Okay, one other picture, if I may. Again, a time scale here for 1 month, 18th of September to the 12th of October. What we did is we gave them 3 weeks with the technology at first. So just using the blood glucose meters with Bluetooth and the phone and learning to do the readings. These are only the readings first thing in the morning, what is called a fasting blood glucose, your lowest readings. This is the normal band, in green here, 4 to 10 millimoles per liter. You can see this person is way out of control, goes all the way up to 32 millimoles per liter. This is very poorly controlled diabetes, and they're all in the red. And they learn to use the technology, obviously doing quite well. This is the weekend, by the way, and great to look perhaps for different patterns. Get them to start using the insulin. You can see the effect already within 1 week. Their blood sugars are coming down pretty quickly. If you run the tape on, this is a different patient, you can see again lots of red at the beginning and then gradually more and more and more green as they titrate to their ideal insulin dose. And this happens in 3 months with no visits to the doctor. Insulin titration usually takes between 6 and 9 months and up to 10 visits to the doctor. This was done, the patient on their own, no visit to the doctor, occasional call to the telehealth nurse. So without going again through all the details of this, in blue is HbA1c, went down from 9.5 to 8.7%, so 0.8% change, and the use of insulin went from 48 units to 64 units. Clinicians saw that improved patient care. The nurses liked it because they find titrating patients very difficult, and the patients liked it as well. And that's important. Do the patients like using the technology? And the answer was very much yes, enthusiasm about the extra support. Even tougher group of patients. Peter Rothwell in this hospital with whom I collaborate in this NIHR BRC is the world's leading expert on the management of stroke patients. And there's a study which has been running for more than 10 years, which is called the Oxford Vascular Study, OXVASC. And we started with patients who had mini strokes, minor strokes, TIAs, transient ischemic attack. And normally, after you've had your TIA, you're sent home, and before you go home, you have a blood pressure measurement in the clinic, and that is used to decide what antihypertensive, so the medication which is going to keep your blood pressure down, how much of it you should take. Because, of course, the highest risk factor for having another stroke, which could be a major stroke that maims you or kills you, is high blood pressure. So it's very important to keep blood pressure down. But at the moment, the way it's done is just one measurement in the clinic before you go home. We started giving to every patient who had a TIA standard blood pressure meter, except it's got a piece of Bluetooth technology which transmits it to the phone, which means that every day the nurses in the stroke clinic review the patients on the stroke webpage we've set up. And we've now done about 250 patients since this slide was done. Mean age 70, nearly a third of them above 80 years, so don't tell me they can't use mobile phone technology. And mass capitation, so we discovered that 35% of the patients had high blood pressure, and we did not know it because we had, again, undersampling. Remember, one spot measurement in the clinic. This is now 3 times a day for a month after you go home. And the most frightening thing to me is that 63% of the patients have had their medication adjusted. They've had to have their blood pressure control medication increase. 128 out of 203 patients, which is 63%, nearly 2/3. That's extraordinary. In fact, Peter Rothwell, I could probably tell you in his confidence, not been worked through yet, but when we come back from holidays in September, we'll switch all his patients, not just the one with minor strokes and TIAs, but everybody from the stroke clinic. He wants to give this technology because it reduced blood pressure, the systolic, which is the first number here, by 21 millimeters of mercury on average. Patient satisfaction, again, very important. The patient questionnaires in the upper 80s, low 90s, people really liked, and they were extremely compliant. We had about 90 95% compliance in doing morning, lunchtime and evening readings, because people understand why they have to do this, and it's easy technology to use if you design it right. One more example, work that I've done with Dr. Andrew Weaver at Churchill people and Professor David Kerr when he was still here, monitoring patients who are on chemotherapy. Now, as I'm sure you know, chemotherapy makes you very sick, it's very toxic, but in inverted commas also does you good because it acts against the cancer. Here what you're monitoring is two things: the temperature to make sure, because of the immune system being depressed by the chemotherapy, if you get an infection, it can be critical. So we look to pick up any rises in temperature, and also whether symptoms are such that the patients are so sick that their dose has to be reduced. Because in this day of genomic medicine, how do they set the amount of chemotherapy you get still today? On your BMI, your body weight, nothing else. Now that will change, but at the moment it's still on your height to weight ratio. So about a third of people get the right dose, a third are underdosed and could have more chemotherapy, and a third are overdosed. And we're now doing a further trial funded by the BRC, looking to increase the dose as well as dose reduction, which is what this trial was about. Because people went home with colorectal cancer, we now moved on to metastatic cancer, to fill in their diary twice a day, temperature measurements, as I mentioned, symptom self-assessment. They're not nice symptoms, I'm sure you know. And again, you get immediate self-care information, but also an automatic alert. And now the engineering task in this was simply modifying this end. That is, somebody, we had green, amber, red. Somebody was in the red, 24/7, the nurse had to phone them back within half an hour of them being in the red. So your phone would tell you, you have generated a symptom score that has put you in the red zone. A nurse will phone you within 30 minutes. Of course, we engineers would do worst case analysis. We have to plan for the network being down. If you don't get a call within 30 minutes, phone, and then there's the landline for the cancer ward. We never failed to miss a red alert, or we haven't so far, but the backup is to phone the direct line of the cancer ward. So the type of things, again, you know, symptom questions and mild, moderate, severe, but reminding you, and the colours don't come so well, that's sort of yellow. Sick once in the past 12 hours is mild vomiting. Sick twice in the past 12 hours is moderate. Sick 3 or more times in the past 12 hours is severe. All of those added up and, you, as I said, scored green, amber or red. All patients that in our first study found using the phones very positive experience. The reassurance they monitored, and I think this is a very important one that we've picked up. Patients don't know if they're going to be treated as being hypochondriacs, and some of them are very, very, very sick by the time they phone, and that has led to patients dying. And some do pick up the phone, you know, as soon as they have a bad headache. Actually, this removes the decision from them. They do their diary religiously, and then the nurse calls them, and that really makes a huge difference. They don't have to make that tough decision: do I or do I not call? And they don't have to worry about being, in inverted commas, bothersome. And we were featured in the Times when there was a big spread. This is a gentleman who was in our study, fantastic garden centre manager from near Whitney. You can't read this, but what he's saying here in the Times article when interviewed by the Times journalist, that I found the sense of being monitored this closely very reassuring. And there's the kind of paper, if anybody wants to read it, in Annals of Oncology that we published on this study in 2007. So what is very important, before I sum up, is I've talked about the benefit in terms of patient outcomes that the doctors want to deliver. But in all of this, and in fact, one of the main reasons for the lecture tonight is about talking to patients, getting feedback. It has to be something that the patients engage with. So the patient case for eHealth, well, you already heard it for cancer. I'm not going to describe this in detail, but this was a fascinating one when we did a study in Southampton. This young man, Southampton University, diagnosed with diabetes whilst at university, and very depressed about it at first. Then he said, I'm going to beat this, and he started doing his blood testing regularly, and he challenged himself to do a sponsored cycle ride from London to Paris in support of Diabetes UK. So he went out with his phone and his blood meter to the swimming pool, riding around Southampton, and he kept a blog, and he's allowed us, every other data, there's no data shown in any of these slides, apart from this one and next one when we have permission from the patients, and of course it's anonymized. So you can see again his plot, and then he keeps a diary and a blog, and here it's dropped right down 2.7, so his comment is sugar, sugar. You can interpret that in multiple ways. Completely other end, a 69-year-old man, also in Southampton, type 2 diabetes, went into hospital, was using 10 units twice a day. What happens when in hospital? The notes got confused, he stopped taking his insulin and so on, but he still carried on with his diary. And in fact, his wife used to upload his readings for him while he was in hospital. So we noticed all of a sudden a well-managed patient, whoosh, telehealth nurse phone said, what's going on? And she was able to get him back on insulin in time for him not to go into diabetic ketoacidosis, which would probably meant at least a week in hospital, because picking up an unusual pattern and intervening immediately. So, to conclude, 2002 was the key date when GPRS 2.5G started being switched on. You've all got your mobile phones on. I don't know a consultant in this hospital that doesn't have an iPhone now, and that's actually true. There's someone here from our stroke project where they're using PDAs or iPhones to assess patients from the moment they arrive to A&E right through the whole stroke pathway, and the information is on their iPhone, it's uploaded. The multidisciplinary team meeting has no paper in there. It's all done electronically and using one of those to display the contents of the server onto the screen. And this is a data acquisition tool if you want. It's a complete change of the way mobile phones are used. We know that patients like the technology. They understand the benefits. You have to design appropriate technology which is personalized, targeted. You don't give everybody the same application. If you're newly diagnosed, you should have different application on your phone. If you're trying to optimize your insulin or your oral medication, likewise, if you're stable, a different application again. It needs to be personalized. I just want to say very briefly, just in case somebody wanted to raise it, I've just got 2 slides on this as I look to the future and wrap up, is that this is not just for the developed world. We're also working in the developing world. Mobile phone technology is extraordinary. It's the one technology which has really probably been even more successful in the developing world than the developed world. So we have funding from the Wellcomes Trust to develop eHealth application on low-cost phones. In fact, my research student came back from South Africa, bought back a £7 Nokia phone, which is black and white screen, probably the ones your mum and dad would really love to have. In South Africa, they sell them for £7. So we're trying to do things with low-cost handsets for the developing world, working with South Africa initially and then India later. And we're looking at women who get diabetes during pregnancy, supporting community health workers, and looking at cardiovascular disease. And I couldn't resist this just as an engineer to show you one slide, and don't worry exactly about what it means. What they're doing is they're taking their low-cost phone, no sensors, nothing, they're switching it on, and instead of speaking, they put it next to their heart. And we're then picking up the heart sounds, first and second heart sound, and I won't go through the details of this, to decide whether somebody's got an abnormally fast rhythm or atrial fibrillation, both of which are highly dangerous. And then we can send them a text and get them into the local clinic, just by putting your mobile phone on your chest. That's the kind of thing you can do in the developing world. What about the developed world? Well, our biggest opportunity and our biggest threat is the iPhone. There are 1,000 medical applications on the iPhone. So people are getting sensitized to the fact you can use your iPhone for health. Both a threat, because if you just download an insulin calculator and don't know how to use it, you could actually give yourself a hypoglycemic coma, or even worse than that, kill yourself. So it's both a threat and opportunity. You have to create validated health applications which are fully integrated into people's lives. So just to run through very quickly, this is the one we're developing on at the moment, still under development as they say. It's an iPhone type 1 diabetes tool. You again get your blood glucose from your Bluetooth meter. You then tell the phone when you woke up, before the meal or after the meal, etc. Then you can look at all the menus. We have 4,000 pictures of foods in different portion sizes. And that gives you automatically the kilocalories and the grams of carbohydrate automatically. That's still not enough for some people, by the way. We've had to develop a speech recognition application. So if you look here, hold to talk, you run, so you don't even have to select this, you just speak it into the iPhone, veggie burger, beef burger, etc. and it's recognized automatically. So, we are really trying to make it easy for the user. And finally, we also need to know about the physical activity. What we started with is recording number of steps in your pedometer in your pocket. Actually, we don't think that's going to work because people are going to type random numbers. So instead, we're using GPS. My student lives in Summertown, or RA lives in Summertown. This is him coming to the Churchill Hospital where our institute is based. So that allows us to know how long it's taken, how many calories have been burnt in going from there to there. And of course, because we know the time, we know whether he's cycling, walking, or on the bus. And finally, an insulin wizard. And I won't take you through all of this, but it teaches you how to calculate your dose given your insulin to carbohydrate sensitivity. Doesn't do the calculations for you, it takes you through the step. Everybody knows what a wizard is. It's a kind of that annoying tool at the bottom of Microsoft Windows. But it helps you to take you through all the calculations, and then it says, having gone through the calculations, what is the number of units, but you still have to type it yourself. That's where we're going long term, because within 5 years, most people will have an iPhone or an Android phone, something very similar to that. So finally, last slide. So I've overrun by about 5 minutes. Telehealth, it's only been around 8 years. So, if you think of the time it takes to bring applications into the community, we're getting there. I've just had an email. Last email I saw before coming here was from the guy who is the telehealth guru for Connecting for Health, doing very good work. In the States, they're starting to integrate it to disease management and reimbursement. But the caveat about the iPhone, only those applications which are properly validated clinical context will survive, because a doctor will not recommend an application until there's evidence of the effectiveness of the intervention. And you can only really adopt it as a patient once you have the recommendation from the relevant healthcare professional. And I'll finish with a quote from the diabetes czar that we saw about 4 months ago, Dr. Rowan Hilson, who said, mHealth is the most cost-effective, she actually said cheap, but I changed it to cost-effective, cheapest form of telehealth available, because it uses the patient's own mobile phone. And that's why it's going to stay here for this decade and beyond. Thank you very much.